This was the spur to developing the next generation gadolinium-based contrast agents. From the previous work, we know that these have got to be stable, they've got to be safe, and therefore it's obvious that these have to be macrocyclic agents. But the challenge was to develop a macrocyclic agent that would give better image quality at the same dose, or potentially the same image quality at a lower dose. So to do that, we have to increase the effect of that gadolinium-based contrast agent. We have to modify it such that its T1 relaxivity, the potency of that agent, is increased. So there are kind of two ways of doing that in the past. One way we can do it is just by making a larger molecule and having slower tumbling. And if we've got slower tumbling with a larger molecule, we will get a higher effect on T1 relaxivity. The other way is to engineer the compound so that you've got more water interactions with the compound, so that in the local environment, because when we look at what's happening with MRI contrast agents, we're not actually visualizing the MRI contrast agent itself, we're visualizing its effect on the local water environment, the local magnetic environment. So what we can do is we can engineer it such that there are more water coordination sites, and on any gadolinium-based contrast, we can affect the water coordination sites in what's called the inner sphere, which is kind of more potent if we can do that, or in the outer sphere. So gadapiclinol is one of the new agents, and that has more water coordination sites both in the inner sphere and in the outer sphere, such that for the one gadolinium atom within the molecule, you'll get a much greater effect on the T1 relaxivity. So these are kind of the two ways that researchers have been looking at this, and gadapiclinol has been through all the safety trials, through the phase 1, phase 2 and phase 3 safety trials. It has marketing authorization and is now commercially available from the companies and can be used for many indications. The other agents, the gadaquatrain, is a new tetramer agent. So this is a larger agent. It's got 4 gadolinium atoms per molecule. These are all in one very large molecule which tumbles slower and therefore also has a high relaxivity. And this has now gone through phase 3 trials and has been put forward for marketing authorization. So it seems to be safe and it seems to be effective. And the trials show that we can get the same effect in terms of contrast enhancement in the patient, but at a lower dose. And all these trials have been done where patients have volunteered to have both a standard classical agent and the new contrast agent, a week or 2 apart, so that we can actually see in the same patient that we can see the same effect, but at the lower dose. So I think these new agents are going to be really useful for patients who we anticipate are going to need multiple contrast-enhanced MRI scans over time, so that cumulatively they'll be exposed to less gadolinium contrast, particularly, for example, in the pediatric population, where we always want to do things at the lowest dose possible. And again, may have a lifetime ahead of them in contrast-enhanced MRI scans. So we're going to have less administered to the patient. I think that means that less will be deposited, and we know that very little of these is deposited, these new agents. And it also means that for each time we dose someone with a gadolinium-based contrast agent, they're going to excrete less of it. So there's going to be less in the environment. So we're heading to a world, I think, where we're going to be using these more and more, and we're having more efficient MRI because we're using lower dose. So the phase 3 trials of gadaquatrain were performed in a large number of patients around the world. There were 3 arms to the studies. There was one where we looked at CNS diseases, brain and spine. There was one looking at pediatric pathologies in pediatric patients. And there was another one where gadaquatrain was looked at in adults in indications for contrast-enhanced MRI that were not CNS. Okay, so other body areas such as liver, such as kidneys, such as angiography, and also in cardiac MRI. And one of the papers at this year's ECR that's of interest is the subanalysis of the phase 3 trial for gadaquatrain, where it was used for cardiac MRI. And it showed that it seemed to be equivalent for looking for scar in patients, equivalent to the standard agent gadabutrol. and that there were small numbers, and I think that's one of the things that would be leveled against this, and we're really only looking for scar. Cardiac MR is unlike brain MRI, where we give the contrast agent and we're looking for lesions. We're looking for, say, metastases, and we want to see how conspicuous these are and how many we find. In cardiac MR, we look for scar, but we look for scar in different conditions. We look for scar in ischemic disease and coronary artery disease, but we also look for interstitial fibrosis type scar in cardiomyopathies, and the small number of patients, 37, was heterogeneous for ischemic disease and other cardiomyopathies. But also in cardiac MR, we tend to quantify scar, so we will actually use either full width, half maximum, or 5 standard deviation techniques to actually look at how much of the myocardium is scarred. So we might say, 30% of the myocardium is scarred, and we use tools to quantify that. And we haven't really looked at that yet in this sub-study. We've not quantified the scar. And the other things that we do in cardiac MR are that we will also use gadolinium contrast agents for perfusion. So we're looking for either sort of qualitative perfusion, just using our eyeballs to see which parts of the myocardium are perfusing versus those that aren't perfusing well due to obstructive coronary artery disease, using a stress agent. But we're moving more to a world now where we're actually using quantitative perfusion, where we're actually able to quantify the actual blood flow per gram of myocardium and look for differences based on that. And at the moment, because none of the patients in this study had that kind of imaging, then we really don't know how this agent performs. That's similar for gadapiclinol. We don't yet know how this performs for myocardial perfusion. And we also use contrast agents in MR for looking for instance, patients with amyloid. We're looking for expansion of the extracellular fluid space, and we're looking for changing in T1 mapping between pre and post contrast scans in order to determine the extracellular volume and increases or changes in extracellular volume that are a marker of infiltrative diseases such as amyloid. And again, these quantitative techniques have not yet been looked at with any of the new next generation gadolinium-based contrast agents, and we don't know whether they're going to perform better or just the same. I'd hope they can perform better, but we don't know that yet, and there's clearly an awful lot of work to do before we know exactly the place of these new agents in cardiac MRI. And similarly, cardiac MRI is one of the last strongholds where we would actually use higher dose traditionally. In my current practice, most of my cardiac MR, I use 1.5 dose of a standard classical agent like adabutrol for my cardiac MR for scar quantification and for T1 mapping. And yet, again, in the OBR study, we're only using single dose, so we don't know the performance of these contrast agents if we were going to perhaps use actually higher doses, which currently are going to be off-label for gadapiclinol, which is the only commercially available agent. So really interesting work on the cardiac MR, but it just throws into focus how much work we're going to have to do before we know the place of these agents.